Hello, everyone, and welcome to my virtual talk, Sensory Differences in Speech-Language Pathology, Working with the Deafblind Community. I'm incredibly excited to be here with you today and hope this inspires you to make your practice and research more inclusive. Just a quick introduction, my name is Kira Rosenbloom, and my sign name is a K on the hand moving upwards, similarly to the sign for therapy, like speech therapy. I'm a first-year speech-language pathology student at the University of Toronto. I'm the 2024-2025 SAC Director Student, and I am also a deafblind intervenor at the Canadian Helen Keller Centre. A quick fun fact is that I love learning languages. I'm fluent in English and French. I would say I'm beginner intermediate with my ASL, and I'm currently learning Anishinaabe-Moan, also known as Ojibwe, because of a recent clinical placement I had in Northern Ontario. Just a heads up for those accessing the presentation through our interpreter, at the end of each slide, I will give the opportunity to look at the images and pause the video. So if this is the case, and you'd like to see me hiking in Alberta or at the Grand Canyon, please feel free to pause the video. All right, so let's jump right into it. A common misconception I hear when talking about SLP services for the deafblind community is that deafblind individuals cannot see or hear anything, as in zero vision and zero hearing, which is definitely not always the case, and far from the truth, as vision and hearing are both multidimensional. If we look at the properties of vision, we have visual acuity, which addresses the clarity and distance in which an individual can see, and visual field, which addresses the areas of the visual field that someone has access to, for example, central or peripheral vision. I'll give you a moment to look at the variety of etiologies resulting in changes of vision. Please feel free to pause the video. If we look at the properties of hearing, we have intensity, which addresses the volume in which an individual is able to perceive a given sound. We have frequency, which addresses the tones or pitches an individual has access to, and symmetry, which addresses the lateralization of the individual's hearing abilities. I'll give you a moment to look at the audiogram demonstrating asymmetrical left sensorineural hearing loss. Now, with all of that being said, working with a client or patient who is deafblind can look very different, as the characteristics of both vision and hearing that they have access to can vary not only from person to person, but in terms of a single individual's expressive and receptive communication. So you might ask, how do deafblind individuals communicate? And there are actually a variety of systems and languages used among the deafblind community. There are sign languages like ASL or LSQ, which can then be adapted to individuals with low vision, to tactile ASL, tactile LSQ, and protactile. There are alphabet-based systems like two-hand manual or Braille, symbol-based systems such as communication boards, also known as augmentative alternative communication, speech-based systems such as voiceover or oral intervening, and communication systems or audiological interventions such as amplification using hearing aids, FM systems, or cochlear implants. Please feel free to pause the video to read the remaining methods. To show some examples, the first image is the Unified English Braille alphabet chart. The second image shows the two-hand manual alphabet chart, and the last image is from the Canadian Helen Keller Centre website, and it shows my colleague and deafblind advocate, Elio Regulo, using protactile at an event with his interpreter. I'll give you a moment to take a look at these images. Okay, with all of these tools, now let's consider how these may be applicable to clinical practice. Literacy support is within the scope of practice for SLPs. So let's look at how literacy can impact communication for a deafblind client who uses two-hand manual for their expressive and receptive communication. To start off, decoding is the ability to identify and then blend together sequences of letters, allowing for text to be recognized and understood. Two-hand manual is an alphabet-based system that uses tactile alphabet, allowing individuals to spell their messages to their communication partner. Because of the expressive and receptive spelling required to communicate using two-hand manual, decoding is therefore an integral skill for successful two-hand manual communication. I'll give you a moment to pause the video and read the case study. If this individual had a decoding problem, without proper supports, they would have limited access to expressive and receptive communication, which can impact autonomy and overall safety. Next, let's consider literacy support for a deafblind client that is a Braille user. Using decoding again as an example, we can see how the ability to decode impacts access to not only language, but mathematics. In Unified English Braille, the number system from 0 to 9 follows the alphabetic letters A to J, where A is 1, B is 2, and so forth. To indicate whether a sequence will be alphabetic or numeric, the number sign or hashtag is used. I will give you a moment to look at the example images on the slides. In this example, if we look at the two Braille transcriptions, the only difference is that the number sign is placed at the beginning of the sequence. Understanding how one symbol impacts the rest of the sequence is imperative to understanding that the first word reads ACE and the second reads 135. If a Braille user had a decoding problem without proper supports, they would have limited access to math and literacy, as well as potential impacts to autonomy. Again, please feel free to pause the video to look at the examples in the photos. While these cases are hypothetical, it's not to say that these scenarios do not exist in real life. In my clinical experience, I've had the opportunity to support language for a deafblind individual living with aphasia, AAC for a deafblind individual with cerebral palsy, and tactile AAC for a blind and bilingual child. Now let's get into some tips clinicians can use to ensure their practice is inclusive. One of the most important things is assuming competence. As SLPs, we know that expressive and receptive communication abilities do not equate to competence, so please make sure to keep this in mind. As per the Accessibility for Ontarians with Disabilities Act, or the AODA, it is mandatory to provide certified interpreters upon request for clients who require them. If you know that your client will be using an interpreter, schedule accordingly. Communication will be facilitated through more than just the clinician and the client, which can take more time. And finally, ensure you communicate information in a way that is accessible to the patient, so no jargon. For example, in some instances, a medical term may not exist in both English and ASL, and you may need to explain the term to the interpreter to ensure they can translate it into ASL. Finally, I encourage you to continue learning. Learn about deafblind culture and communication, and don't be afraid to ask your client questions. No one understands their communication better than them. One of the last things I wanted to touch on was the prevalence and representation of deafblind individuals in research. One thing I've often been told is that my interest in working with the deafblind population is very niche, and that there are not many deafblind people who would even require speech and language services. To put this into perspective, let's look at the prevalence of deafblind individuals versus children with childhood apraxia of speech, or CAS, in Canada. In 2022, the Canadian Helen Keller Centre released a report stating that over 1% of Canada's population is deafblind. In 2023, SAC released a resource stating that childhood apraxia of speech affects less than 1% of children in Canada, which would suggest that there are a greater number of deafblind Canadians than there are Canadian children with CAS. Now, if we look at how this is represented in research, we can see that CINAHL was able to give me 6 different randomized control trials pertaining to CAS and 0 pertaining to deafblind individuals. With the special interest set to speech-language pathology and audiology, CINAHL was able to give me 34 articles on CAS, but only 14 articles pertaining to deafblind individuals. And when I opened the search further, CINAHL gave me 185 articles with CAS in the title, but only 135 with deafblind in the title. I'll give you a moment to look at the search results. I wanted to point this out in particular, as research is what fuels clinical practice. Clinicians turn to research to help them make informed decisions and provide evidence-based practice. Without the body of knowledge, we are not equipping clinicians with the tools needed to support deafblind clients and patients. I want to leave you with a quote that I really like and one that I try to live by. There's nothing I can't do, only things I can't do yet. Exploring new areas can be daunting, but I hope this presentation inspires you to take action and help ensure that healthcare is accessible for all. You are capable of learning these tools, and you are capable of working clinically with the deafblind community. Like the quote says, there's nothing you can't do, only things you can't do yet. With that, here are my references, and thank you so much for stopping by and spending the last 10 minutes with me. If you have any questions, please feel free to reach out. Thank you, and bye!